Failure.
Which one is acute?
Respiratory failure.
Distress.
Distress. Failure is more chronic. It's a progressive, long process that ends up leading the patient to end up with respiratory failure. Acute respiratory distress is the one that is acute. That is the one that is caused by gunshot. That's the one with a stab wound or blunt trauma to the chest. So that's the one that is acute. Failure is the one that is chronic. That's the one that's going to be, is going to take a little while before it happens. Okay, for those who just now joining, I know you can't see the link in the chat, so I just reposted the link. Make sure you select course specific. So, okay, pneumothorax. Now let's start with pleural effusion. What is pleural effusion?
Fluid in the lungs.
Fluid in the lungs. So when you listen, what are the symptoms of somebody who have pleural effusion? All the apneas, dyspnea, tachypnea, orthopnea. And when you listen to the lungs, what happens? You hear? What do you hear?
Crackles.
Crackles. Very good. So, of course, because you are having respiratory issue, and ladies and gentlemen, remember this, okay? When you have a patient who's having issue breathing, we already know what's going to happen to the heart rate. Up or down? Anybody?
Increase.
Increased. Very good. So you're going to end up with tachypnea, dyspnea, right? And also tachycardia. What does that do to your cardiac output?
Decrease.
Decrease. I want you guys to relate all of that into one. And we already know saturation is going to drop. So what is the procedure to remove that fluid in the pleural space?
Chest tube.
Not yet.
Oh.
Thoracentesis.
Thoracentesis. Thoracentesis is an ultrasound guided using local anesthesia. They're going to locate the pocket of fluid in the pleural space. So what is the best way to position the patient? Of course, sitting upright. You're going to get the meal table. You're going to put it in front of the patient while the patient's legs are dangling on the side of the bed. And you're going to put a pillow. Tell them to rest their elbow and overlap their hand and rest their forehead on their hand while the doctor is behind them. So for the meantime, you're in the front and you need to make sure you observe the patient closely for any respiratory changes. Now, doctor will order chest x-ray after the thoracentesis. What is the possible complication that the doctor is making sure the patient didn't end up with? Remember, there was a fluid in the pleural space, so he removed it. But he wanted to make sure that pressure in the pleural space didn't change. So what is he looking for?
Improve the SO2.
Well, what
Improved
complication? Hold on.
respiratory.
What
Collapse.
collapse? What is another name for? It's
Pneumothorax.
Pneumothorax, you mean?
pneumothorax. Yes. Pneumothorax is not necessarily a collapsed lung. Pneumothorax, the pleural space surrounds the lungs, right? So if there's any alteration, increase in the pressure in that pleural space, it's going to push against the lung. That's why the lung cannot fully inflate. That's why they, in common words, they would refer to it as collapsed lung, but it's not really the lung that's collapsing. The lung is just not able to inflate because of the increased pleural space pressure. All right, so if it's an open pneumothorax, what is one nursing intervention that we can do for that? Okay. I muted you, Shani. What can we use? Occlusive dressing, sterile occlusive dressing, taped on 3 edges, not 4. Because again, when the patient breathes out, the air can come out because it's not taped on 4 edges, just 3. When the patient breathes in, that dressing will get sucked in and seal that hole. That's for open pneumothorax. For closed pneumothorax, Evelyn, now you tell me what is the solution for that.
Chest tube.
Very good. I told you there's no wrong answer in this workshop. If you give me an answer and it's not good for that question I'm asking you, I'll go back to you and make you right. Okay? All right, so chest tube. So this is done by the provider. And so they're going to insert the chest tube. And then that chest tube connects to the long tubing that connects to the water seal chamber, collection chamber. So initially, when you connect that, there's going to be bubbling on the water seal chamber. But once that influx of air goes in and it's a sealed drainage, what are we supposed to see in that water seal chamber that indicates our chest tube is working?
Idling.
Tidalling, absolutely. Tidalling is the rise and fall of the level of the water in the water seal chamber as the patient breathe in and breathe out. Okay, so what happens when we saw that tidalling, then 2 days later we see a continuous bubbling in the water seal chamber. What does that mean?
A leak.
A leak, an air leak. Very good. Do we ever milk a chest tube?
No,
Never, right? Do we clamp a chest tube?
no. Unless you're
Never.
trying to change it.
Well, like I said, the only time you will clamp it is if something got disconnected, right?
Mhm.
And if it gets disconnected, what is the better way to handle it other than clamping?
To put it in stir water.
Very good. Put the tip of that chest tube that is still inside a patient, right? Part of it is inside a patient because we want to create the same seal as the water seal chamber. So you're going to put the tip in a sterile bottle of sterile saline. Very good. What do you
Stir
have?
water or sterile saline?
I'm sorry, sterile water.
Okay.
What if the patient now accidentally pulled that chest tube? What do we need to have at the bedside?
You always need the ambu bag
No, no,
and
no.
oxygen.
Hold on, listen. The chest tube gets pulled out. What do you need?
You need that
Oh,
occlusive.
Occlusive dressing.
sterile
Occlusive,
occlusive.
sterile occlusive dressing. Very good. All right, so let's see what else. So let's move on from that. Let's talk about CVP, central venous pressure. What is that? What can cause a drop in the central venous pressure?
Can you repeat your question?
Hypovolemia.
Hypovolemia can lead to low CVP. So what is the nursing intervention that we will expect the doctor to order?
Fluid.
Fluid?
Fluid resuscitation. The only thing you need to watch out for when you're doing any type of fluid resuscitation, whether it's dehydration because the patient is throwing up or is dehydrated, what are the two types of patient that you need to be careful how much fluid you're giving in?
Heart failure.
Heart failure and
Kidney failure.
kidney failure. Very good. Heart failure and kidney failure, there will be in fluid restriction, so you need to be careful. Who else? Just to add to that, a patient who keeps on third spacing, let's say anasarca, generalized edema. You keep on giving the patient fluid. If there's a reason, if there's physiological reason why the patient is not keeping the volume in the intravascular compartment, the more fluid you give, the more that swelling is going to get more, right? Is going to increase. So that's when you need to understand the type of fluid, how they select it. In small amount, which of the IV fluid will they use if there's third spacing and the patient need volume, the intravascular?
Albumin.
Albumin is a volume expander, but what type of fluid is an alternative? You got your hypotonic, isotonic, and hypertonic. Which one?
Isotonic.
Not if you want to direct the fluid from the tissue that is swollen to the intravascular. I'll give you a hint. Osmosis.
Inotropic.
We need hypertonic. And there's only going to be a small amount, 200 cc's, 300 cc's. The doctor will order that, and you have to observe the patient closely. What it does is increases the concentration, the intravascular compartment, so we can pull the fluid in the wrong places to go to the right place, which is intravascular, where we want it to be. All right. So, what would increase the central venous pressure? If hypovolemia decreases it, what increases it?
Hypervolemia.
Hypervolemia. Very good. So what would we expect the doctor to order?
Diuretics.
Diuretics. What are the things we have to remember as nurses when we're taking care of a patient who's taking diuretics?
Always check their weight.
We'll have to check the weight daily.
Electrolytes.
We'll have to check the weight daily, early in the morning, to make sure that if we're trying to diurese the patient, you're looking for a weight drop, because every time they lose 2.2 pounds, which is equivalent to 1 kilogram, is equivalent to 1 liter, which proves that our diuretic is effective. What else? So you said check electrolytes. Absolutely. When I say potassium, what comes to your mind?
Heart.
Heart. When I say sodium, what comes to your mind?
Brain.
Brain. And what else?
Infusion.
Fluid. Fluid, right? If I say calcium, what comes to your mind?
Neuro.
Calcium.
Muscles.
Muscles. Very good. Muscles. All
I was
right.
switching.
So 3 ways. Well, actually, there's 4, but I want you to focus on 3 ways that the patient can lose fluid and electrolytes: vomiting, diarrhea, NG tube to suction, and later on during this term, you're going to learn that burn patient. Because again, what happens to tissue when it gets damaged? It swells. Why does it swell? It pulls fluid towards it. And where does it pull it from? From the intravascular. And during that shifting, electrolyte comes with it. So one of the things, remember, airway, breathing, circulation. Circulation is going to be the third thing, because airway and breathing is the high priority. We have to keep the patient breathing. We have to keep the patient alive, right? But we also, it's just as important to make sure that we check the fluid and electrolyte status of the patient, because although fluid, okay, yes, it will affect the circulating blood, but those electrolytes can also affect certain organs, certain part of the body, and we need to stay focused on that as well. All right, so what are the components of stroke volume? You learned this all the way in fundamentals. Stroke volume, preload. What is preload?
The filling of the heart.
The amount of blood that fills in the ventricle, that stretches it. And remember, the more it stretches, the harder the contraction would be, right? What is afterload? See, when you're taking care of a patient who is critically ill, it's very important for you to understand these components. That's why I'm bringing it up to you. Like, I think you're very aware now, right? The standardized testing None of us know what they're going to ask you. So I'm just making sure we cover all angles. Afterload, what is it?
The force it takes to eject the blood back into the body.
The pressure that the ventricle have to push against. And then there's also the contractility. All three components is part of that stroke volume that you always remember, stroke volume times heart rate. Here's what you have to remember. Perfusion is number one in your list. Patient need to be well perfused. What does that mean? Patient need in every inch of the patient's body, they need oxygenated blood, tissue and organ, both, right? If the patient's stroke volume, the volume is high or low, what happens to the heart rate? Doesn't matter if it's high or low, what happens to the heart rate?
Goes up.
It goes up. So you see, it doesn't matter if your volume is low or high, patient's cardiac output will be affected because it forces the heart rate to pump faster. Heart rate times stroke volume, remember? Now, if the heart rate is low or high, cardiac output is compromised. That's why in that circulation part, remember you need a good pumping heart, a good volume, and a clear pathway of the circulatory. There cannot be clots, thrombus, any plaque, any narrowing. There cannot be any of that because for that heart, a good heart, and they have a good volume, right? That's converting unoxygenated to oxygenated. But what good would that do if there's a clot, there's a narrowing, there's a blockage, there's a problem with the path? So you need all three for that circulation part. All right. Somebody tell me about systemic vascular resistance. What can increase it? What increases systemic vascular resistance?
Blood pressure, high blood pressure,
What causes it to go up?
vasoconstriction,
Very good. So what do they use to treat an
Um,
increased systemic vascular?
norepinephrine, epinephrine,
What is norepinephrine and epinephrine?
Vasodilators. Vasodilators.
Those norepinephrine, let me just address this first. Norepinephrine and epinephrine are all positive inotropes, which causes, Ashley, what does that positive inotropes do to the
Increases the blood pressure, so you would need negative inotropes, right?
negative inotropes? Ashley, what did you say?
They vasodilate.
Vasodilates, and that's the negative inotropes. Negative inotropes are your calcium channel blockers, beta blockers. Nitroglycerin is a vasodilator, right? Remember that with the MONA, right? Nitroglycerin causes peripheral vascular dilation. Okay, so pulmonary artery line, which ventricle does it measure? Without being wedged.
The left.
That is if they wedge it, right? But pulmonary artery line, PA line. Hold on. Okay. So what I want you guys to remember is this. The PA line can measure the right atrium, right ventricle, pulmonary artery pressure, and also the left ventricle if it's wedged. What do I mean by that? Let me see if I
Can
can.
you repeat that? It measure PAV measures the left ventricle,
Hold
right
on.
atrium.
I'm going to show you the picture. Hold on a second. Because it's easier to. All right, here we go. CVP measures which ventricle?
We don't see any. Oh, okay.
CVP, central venous pressure, which ventricle does it measure? Right or left?
right?
Right, very good. So this is your PA line. So when the doctor said, I need somebody to help me, I'm going to watch that PA line. This is what they mean. So first, you're going to leave the tip in the right atrium to measure the pressure. So in your paper, you're going to put RA for right atrium, RV for right ventricle, PA for pulmonary artery, and then PAWP, pulmonary artery wedge pressure. All it is as the doctor advances it, it's measuring certain part of the heart's pressure. Right atrium will measure right atrium pressure. Ventricle, so this tip, forget this, right? It's still here. Right ventricle pressure. And then he's going to put it right there in the pulmonary artery without inflating the balloon yet. That's pulmonary artery. Once they inflate and it wedges, right? Just like you wedge a door. You keep the door open, right? You wedge that. Now it's measuring the capillary bed pressure in the lungs, also the left ventricle. Why? Remember, we said that the cardiopulmonary blood flow starts with superior inferior vena cava, brings in the unoxygenated blood to the right atrium, right ventricle, pulmonary artery to the lungs, pick up oxygen, left atrium, left ventricle, and out the aorta is oxygenated, correct? So once they wedge that, the pressure that it's measuring is the one past this one, which is the capillary bed on the lungs, and it can also measure the left atrium, left ventricle without being advanced because again, it will be reflective. Now, you're going to hear terminology such as ejection fraction. Why is that important? Because that's reflecting the amount of blood, the ability of the heart to pump the volume of oxygenated blood that is measured by transesophageal echocardiogram, TEE. Trans across esophagus from the esophagus, so the scope will go down the esophagus, and then once it's down, they're going to look across. That's why it's called transesophageal echocardiogram, looking cardio, looking at the heart. This one is just the line being advanced from right atrium, right ventricle, pulmonary artery, and then they wedge it. Once they wedge it, now you're measuring again. See? You're measuring again the pressure in the capillary, but also the left ventricle. Okay? Any question? So, let's talk about A line. What is A line for?
Continuous ABG.
Repeat, repeat, constant, repeated ABG. Why is ABG so important? Who gets frequent ABG measurement?
Ventilator patients.
Ventilator patient. What is the significance of that? How does that connect? Okay, I'm in a ventilator. Why you keep on taking my arterial blood? Why is that important?
We want to see if they're ventilating correctly, oxygenating.
Oxygenation. Because the ventilator have settings, and we're going to cover that too, right? Because again, the purpose of the ventilator, the mechanical ventilator, remember, they will use fancy terminologies to refer to oxygenated blood, right? Oxygenation versus what is the actual ventilation is the act of inhalation, exhalation, right? Oxygenation is the exchange of carbon dioxide and oxygen in the alveoli. So you need to understand those basic anatomy when you look at mechanical ventilator. Now, as they titrate down the setting, that means more and more the patient is doing more for their own self as opposed to the mechanical ventilator. That's what it means when they say they are titrating the setting. Now, we need constant arterial blood gas to determine if the patient is tolerating the titration. That's why they need an A line. But what is the test that they do before they insert an A line?
Allen test.
Allen test, what is that? What are we comparing? What is this?
Relation.
What is
It's the
this?
ulnar and radial.
Radial, and the
And the
ulnar is
ulnar.
here. So what you do is you press down, right? And you make them clench their fist. So when they open, if you're pressing on both pulses, that means your hand will be pale as my hand is, right? So what you do is you release one and you see how it changed back to color. So I'm going to press this other one and you see now it changes too. It determines the good perfusion that the radial and ulnar are working good and giving that tip of the hand good oxygenated blood. That's what you're testing for. Because what type of blood flows in the artery?
The one
Oxygenated
full
blood.
of oxygen.
Oxygenated blood, right? That's why we have to make sure that we get good circulation first before we. What is the difference if you stick an artery and you stick a vein?
A vein is deoxygenated blood.
Vein is unoxygenated, artery is oxygenated. What else?
The vein one is darker, artery is brighter.
Right.
The artery has more pressure, so
Very good.
when you're done with blood draw, you have to put 5 minutes pressure versus venous, you only need a minute or maybe less based on if
Right.
they're on anticoagulant or something.
Right. So you have to, I'm glad you point out that good factor, right? That you have to make sure. That's why before you take care of a patient, before you go into the bedside, before any of that, right? When you start being assigned patients, one thing you might want to go ahead on and take a look at is the patient is full code or no code or chemical code only. Whatever is the status, you need to make sure you know. Because if you code that patient and you revive them, you can actually lose your job
I
if
have
the
a question.
patient is a no code.
What if you didn't know? Like you missed it. You look at the chart, but you missed
No,
it.
if it's in the chart and you missed it, that's still not an excuse. That's why I said you always have to check. Okay. So now if a patient comes in into the emergency room, we don't know this patient. This patient coming from out of town, we don't have a second to check and call a family member or anything. We're going to treat them as full code. But if you have it in the chart and you have access to the chart, then yeah, that's a no-no. Okay. So A line, continuous blood monitoring and frequent ABG draw. ABG, pH, normal pH is what?
7.35 to 7.45.
Give me the HCO3, Ashley.
It's 22 to 28.
22 to 28, 22 to 26. How about the carbon dioxide?
35 to 45.
Very good. Oxygen?
It's 80 to 100.
Very good. Very good. So any problem with compensation? Please raise your hand if you have an issue with compensation.
Yeah. Yeah.
Okay,
I-
so, all right. So as far as compensation, you just have to remember one thing. What do you have to look at to determine which was the first component that you have to look at when you're looking at ABG?
CO2 and the
pH.
O2 first, right? And then the pH. Why is the pH important?
It's going to tell us whether it's acidotic or alkalotic.
And what else? Because as soon as we move to the next component of the ABG, what is that going to tell you? It's going to help you determine if it's metabolic or respiratory. What is the rule of thumb with Rome? Respiratory, opposite, metabolic, equal. Which is the component of the ABG that represents metabolic?
bicarbonate.
Bicarbonate, the HCO3. So if the HCO3 and the pH goes the same direction, you're looking at something metabolic. So again, your pH is the one that's going to determine if it's alkalosis or acidosis. In the same token, respiratory opposite. That means your pH and the PaCO2 goes opposite. If your pH goes opposite direction as the PaCO2, then that means you're looking at respiratory. And again, you're going to check the pH to determine if it's respiratory acidosis or alkalosis. Now, going to the compensation. I want you guys to remember this. Compensation is very easy. But always, as being in the advanced med surg, you always want to look at your PaO2 because if the patient is hypoxemic, we don't care about the rest of these. Hypoxemia is your number one priority. Now, as far as compensation, if your pH is normal immediately, you know it's a full compensation, meaning to say the metabolic and respiratory work side by side and they successfully normalize the pH. That's why you know it's full compensation. But remember, we need to have either acidosis or alkalosis on the pH. So we're going to consider 7.35 to 7.40 as acidosis and 7.41 to 7.45 as alkalosis. Now, if all your pH, HCO3, and PaCO2 are all abnormal, you have a partial compensation. That means the metabolic and respiratory try to work hand in hand, but didn't quite normalize the pH. That's why you know it's partial compensation. Now, if one of the components that represents respiratory, which is PaCO2, or the metabolic, which represents the HCO, is represented by HCO3, if one of them is normal, then you know you have an uncompensated. Any question? No question? Good. Let's keep on going. So, let me see. What else did we miss? Keep positive and expiratory pressure. What does that do?
It keeps the alveoli open.
Very good. It applies a certain amount of pressure towards the patient when they breathe out, which prevents the complete collapse of the alveoli. It helps the patient spend less energy on the process of inhaling and exhaling. What is SIMV? Synchronized intermittent mandatory ventilation. Patient is set, if the SIMV is set to, let's say 18, and the patient only breathes 10, what's going to happen?
You need to increase the SIMV.
The mechanical ventilator will breathe that remainder. If it's set to 18 and it's 10, then it will breathe 8 breaths for the patient. So how about FiO2? What is that?
Fraction inspired oxygen.
Inspired oxygen. So what does that mean?
It's the additional oxygen that we're providing to the patient.
What is a normal FiO2 in room air?
21%.
Very good. Very good. So usually the FiO2 that they set the mechanical ventilator for is between 30 to 100. So how do you know the patient needs suctioning?
If
The
you see them
ventilator.
using, go ahead,
Go ahead.
accessory muscles, if they're using their accessory muscles, if their vital signs are off,
Okay.
The
But
ventilator will high pressure.
very good. So what is more important, high or low? Not to say we're going to ignore one, right? What would cause the patient to have low pressure alarm?
Disconnection.
It can mean that there is some type of leak. It can mean the patient extubated themselves, right? And it can mean that the patient is not properly and adequately getting any ventilation. But what would cause a high pressure? You mentioned already secretion, right? What else? There might be a kink, right? Or sometimes they bite on the endotracheal, right? So again, do not be looking for, oh, high or low alarm. Just always remember, right? Yes, the pressure is going to alarm, but what else? There's other things you can do, right? Look at the respiratory rate, look at the saturation rate, right? And look at the use of accessory muscle. Remember skin color, you learned this in basic assessment. This is the time wherein you pull all the stuff that you learned from fundamentals, introduction, intermediate, basic assessment, advanced assessment, everything that you know. Don't just look for high alarm, low alarm when you're looking at what would indicate the patient needs suctioning. So tell me, what is the first thing you need to do before you suction?
Hyperoxygenation.
Hyperoxygenate the patient. What does that mean?
You basically give them 100% of oxygen for at least 20 seconds, I believe. And then before you can suction, because suctioning is basically like the patient can't breathe or get oxygen.
Okay. What type of gloves do you use? Do you need the sterile gloves?
For open, yes. For close, no.
What do you mean open and close?
Um, Open suctioning when you have to have all the equipment and close is when they're in a ventilator and they have the suctioning.
The closed system suctioning?
The close is
Let me ask you this. If it's a closed system, what does it mean when it's a closed system suctioning?
That you don't really access it, so you can use your clean gloves.
Clean gloves. Because it's a closed system, right? Now, if you're talking about we're going to suction the patient's trach, yeah, we don't want just regular suction gloves for that, right? Because again, if it's open, then we don't want to use just regular gloves. So let me ask you this. When do you apply the suction? Inserting the catheter or on the way out?
On the way out.
On the way out. How many times is customary, is safe for you to suction the patient at one time? Can we keep on suctioning?
Isn't it 10 to 15 seconds?
That's how much you will suction. No more than 10 to 15 seconds. But how many seconds or is what's the interval that you wait before you suction again?
I think 1 minute to 2 minutes in between your suctioning.
1 to 2 minutes, right? You will hear 20, 30 seconds, 60 seconds. But the point is, understand that there's an interval. You're not just going to suction and then put the catheter back in, then suction again. You have to give them a chance to breathe.
So you
What
give
am
them 1 to 2 minutes break time for them to breathe, but you suction 10 to 15 seconds at a time.
that's what the other lady said. So you're gonna suction for 10 seconds, but you're gonna wait 1 minute at least, 60 seconds, right? What else do you have to remember? When you pull out and you're applying the suction, you're supposed to twist side to side to make sure you get that secretion. What else? What would facilitate an easier suctioning of that sputum, of that phlegm? What do we need? We need some
Is
type of saline
physiotherapy
drops, right? We have to apply saline drops to,
what
again,
to where?
to moisten.
Well,
If
where do you
it's
put it in?
in the closed suction, closed system suction. Let me see if I can find a picture.
We never learned.
So when you see a patient suction, let's see. Trying to see if which one is a good picture. Let me see if I can show this to you. It's usually right there with the suction. You see how this is suction, right? It's of course this strap. This is just for demonstration. This is pretend, right? So you see here, this one is usually twisted, so it won't keep on suctioning if somebody mistakenly press it down. But there's always an opening wherein you can actually drop those saline drops. And again, that's very important because it's easier to suction sputum if it's moist as opposed to dry. You see here? That's the suction wherein you press the thumb and usually that will twist. And right here. You see? You see it?
Yes,
Like
yes,
that?
thank.
So there's always an opening. Now, again, once you see one, and then it might look different than others, but you'll find that little opening wherein you can actually apply that saline so it will be moist. Okay, what else did we miss? Anything else we miss? Familiarize yourself again with mean arterial pressure. What is mean arterial pressure for? It's good to determine if the patient is well perfused. What do we need for mean arterial pressure?
Need as in
Um,
term value.
Yeah,
Anything over 60, but less than 60 would be would mean that they have low perfusion.
okay. And what do we use to get that 60?
Blood pressure.
Blood pressure. And what's the formula for mean arterial pressure? Anybody? It's systolic plus twice the diastolic divided by 3. What is the difference between pulse deficit and pulse pressure? Pulse pressure, blood pressure. All you have to do is find the difference between the systolic and diastolic. Pulse deficit is when usually this is very good when you want to see if the patient possibly have atrial fibrillation because pulse deficit is the one that's one of the easiest way to assess a patient who would probably end up, who probably have atrial fibrillation. When you feel the radial pulse and at the same time you listen to the apical pulse, you will see that there's a difference. It's not in sync. Okay, let me see what else. Anything else that we missed, guys? What else did we miss? Let me look at.
Professor, can I also bug for the link for attendance, please? Sorry.
Oh, no, not a problem.
Thank you.
You're welcome. Yeah, please, everyone, make sure that
Me as
you
well, please.
check in because this automatically recorded in your record that you attended today. I just want to make sure, give me a second. I'm going to look at your course syllabus. I want to make sure that we covered all of it. We did the respiratory failure versus respiratory. So are you guys familiar with the dysrhythmia? I know that's for this week, right? Whoever is gonna. Oh, here, neuromuscular blockage or neuromuscular blocker. When do they give a patient who's critically ill? Neuromuscular blocker.
When they're intimidated.
When they're about to be intubated. Very good. It blocks muscles, the nerves muscles. So again, the muscles have to be completely relaxed, right? Let's see, what else do we need to cover? We did the pneumothorax, hemothorax, mechanical ventilator. We did the CVP, PA, A-line. Oh, what is it that you have to do with the A-line? If you have inconsistent finding, inconsistent blood pressure with the arterial line blood pressure and the non-invasive, what do you have to do?
It's not in a proper placement.
It's not that.
Zero it.
Zero it. And what do you need to zero it? You have to locate what?
Photostatic axis.
Phlebostatic axis. And what do you have to do with that phlebostatic axis? What do you have to do with the phlebostatic axis? What's so important about locating the phlebostatic axis?
Do you put it on the fourth intercostal space?
Yeah.
Fourth intercostal mid-chest. So we located it. So what's the significance? Why is that important when we zero an A line?
If it's too high. Or
Because when you zero it, you need to align the transducer with that marker, with the phlebostatic axis. What is the transducer? It's this one. You see that? That is your transducer. That's the one that you need to align. And so you see, your arterial line blood pressure monitor, the blood pressure coming from the A line is in red. Okay, let's see. So this is what usually you'll see. Okay. You see how one of them is in white, one of them is red. Your A line reading is always going to be in red. And so if there's a difference between that, a little difference, you should be okay. But when this one is reading 142 and this one is 126, then there's a big difference, right? Then you need to zero it. But when do you actually need to zero it? At least once a shift, which in the case of ICU is every 12 hours. Let me see. So when they intubate the patient, what is the quickest way that they will use to see if the patient is or the endotracheal tube is in place?
Chest x-ray?
That's going to take a while. We need to insert the patient, we need to ventilate the patient already.
Isn't the first one is the CO2 line and then ABGs?
So
Like right then you do the CO2, but once you're done, you run an ABG.
the first thing that they will do is they're going to connect this to the ET tube before they connect it to the mechanical ventilator. This will change color, indicating that the patient is blowing out carbon dioxide, which we do blow out when we breathe out, correct? So that's what you call CO2 detector, right? So this is what you're going to be looking for, because you guys are going to be going to clinical. And if there's a code and they ask you, get a CO2 detector, you need to at least know what you're looking for. Okay? So it's a little gadget, they'll attach that. Okay. Now, what is the next one? They're going to listen to the lungs, right? Because, here you go. ET tube here goes all the way down here. They're listening to the lungs because if it's right there where the carina is, right? If it's not further than the carina, past the carina is right here before it splits the left and right bronchus. So if it's not too far, if you listen to the lungs left and right, then you should be able to hear some type of air movement. But if you're hearing one side, there's air movement, the other one is not, that means the ET tube is too far in, then that's when they pull it back a little bit. Okay? Now, we talked about pneumothorax. So again, this is a picture of your pneumothorax, right? Pleural space, increase pressure. But if you don't address that, then it becomes tension pneumothorax. How do we know it's tension pneumothorax?
There will be a tracheal deviation.
tracheal deviation because the pressure is so much. See how it's supposed to be aligned, right? That's the trachea. If this pressure keep on increasing and increasing structurally, it will push towards this side. So now your trachea will be deviated and it will be this way. Okay. So that's why we don't want that to happen. Now, remember there's open and closed pneumothorax. So for open, they can use that occlusive dressing taped on 3 edges, not 4. If it's closed pneumothorax, then that means they're probably going to use the chest tube. Any question? Wow, this is good time. Any question? So let me look at, make sure that we're not missing anything. Let me look at your core syllabus again. Let's see. So we covered the neuromuscular blocking agents with chest tube. We did, oh, so you're supposed to do the pharmacology made easy, guys. Did you know that? Yes? No, maybe? PE. There you go. PE. What is the blood test to find the PE? What did they use?
D-dimer.
D-dimer. So once they do that, then they use the venous Doppler study, right? And then so again, when there's a clot issue on the patient, which is that problem with stroke, because that's a clot that actually block flow to certain parts of the brain that causes the patient's brain tissue to die, is caused by a clot. Myocardial infarction, same story, it's a clot. And pulmonary embolism is the same thing, right? Pulmonary. So most of your symptoms, if they give you select all that apply. Remember, that's going to be mostly respiratory issues. Let me see. So we don't want further clots, so they're going to use heparin. Heparin, what lab test would they use to titrate up and down?
APTT.
Activated partial thromboplastin time. Very good. If it's too high, meaning to say it's taking the blood longer time to clot, to stop a bleeding, what would the doctor order to bring it down some? Antidote for heparin is what?
Prothrombin sulfate.
Protamine sulfate. Very good. Protamine sulfate, right? So the reason why I ask you the way I asked you the first time is because that's what they're going to ask you. They're no longer asking you for antidote. They're going to tell you, okay, patient was admitted for pulmonary embolism is now receiving heparin, IV drip. Which lab test would you expect for the doctor to order daily to monitor the heparin? Your answer is activated partial thromboplastin time. Because this is a good question in an unfolding case wherein, okay, now that the patient is starting on heparin and the patient is getting a PTT drawn every morning, if the APTT is high, which one, what would you expect the doctor to order? The answer is protamine sulfate. So patient go home, the doctor decide to put them on anticoagulant, continue Coumadin, Coumadin will now they look at which lab test, PT-INR. INR is too high, what would you expect the doctor to order?
Vitamin K.
Vitamin K. Very good. And that, ladies and gentlemen, is how you do that. Now, I want you guys to remember something. Let this first quiz, when you guys do the dynamic quiz, practice test taking as opposed to memorizing the question and the answer. If you memorize the question and answer, it won't do you any good. Now, through the test and not the exit exam and definitely not the board exam, because you will never see the question that ATI is asking you in the board exam. It's completely different. What you need to use the dynamic quizzes for is to assess if you really fully understand the topic, because it's very important that you learn the topic from beginning to the end, inside and out, sideways, up, down, upside down, top and bottom. What do I mean? As you progress in the learning the system disorder, you need to make sure you cover all that Maslow's physiological needs. We already know the airway, breathing, circulation, but the nutrition, hydration part in a critically ill patient, which lab test would they use to determine nutritional status of the patient? Anybody?
Is it albumin?
Pre-albumin for the critically ill. Albumin if we got a walkie-talkie.
What about CBC?
Huh?
CBC?
What is CBC, Rebecca?
Well, I know what is CBC, but you can't tell the nutritional.
That's why I'm asking you, what is a CBC?
Oh, it doesn't. No, because that shows the blood count.
So that you can assess the white blood cells, right? The RBC or hemoglobin hematocrit, and also the platelet. Because platelet, if it's low, patient is at high risk for bleeding, right? If WBC is high, means what? If it's elevated, what does that mean?
Infection.
Infection. If WBC is low, what does that mean? WBC that is low, what does it mean?
Is there inflammation?
WBC that is low, what does that mean? What is the
The
white
immunocompromise.
compromise? Compromise immune system. So you need to know that, because if you're looking at the CBC and you see white blood cell is low, what are you going to ask the charge nurse to make available for your patient? What type of room do you need to put the patient in if their white blood cell is low?
Protective environment, so positive
Positive
pressure.
pressure.
Positive pressure. Very good. You see? Patient is highly contagious. What room are you going to ask for?
Negative pressure.
Negative pressure. This is the reason why you need to understand these things. Platelet that is too low, what precaution would you put the patient in?
Isolated.
Is
What
it
type?
Bleeding contact.
Bleeding precaution.
Mm.
Meaning to say, you're going to be very careful. Aside from bleeding precaution, soft bristle toothbrush, no flossing, all of that. Don't let the patient walk with bare feet, right? Because they might step on something. And what else? You're also going to make sure that you activate fall precaution, which you learned in fundamentals. Bed on low position, right? Side rails up, 3, not 4, because it's a restraint. If you put 4, bed alarm, because you don't want the patient to fall on their head. If their platelet is low, that put them at high risk to bleed. If they fall, simple fall can really make the patient get worse. Okay, so again, electrolytes. When they give you a whole bunch of electrolytes, make sure you check the potassium first, because remember, potassium, cardiac. High or low patient's potassium can cause the patient to have dysrhythmia. Dysrhythmia equals poor cardiac output. Poor cardiac output meaning to say poor perfusion. Poor perfusion equals poor oxygenation. You see? Still, when you're studying, make sure you know about Maslow's physiological needs. Airway, breathing, circulation, we already talked about the heart. Heart have to be pumping good, contracting good, volume have to be good, and circulatory system must be good. But remember, nutrition, hydration, that's why you watch their fluid and electrolyte imbalances. And you also make sure you look at that pre-albumin for critically ill, and again, albumin for patients who are not so critical. But elimination, both bowel and bladder, is very important. Every time, and remember this, every time the doctor order an IV fluid, an ongoing IV fluid, you better take an accurate intake and output. Why is that? That's how we can tell if the patient is having too much fluid and not being able to excrete. What happens when the patient doesn't excrete? Remember, especially urine. We talked about this earlier. What increases central venous pressure again?
Hypervolemia.
Okay. So what happens if the patient, that's why you need to be careful when you're hydrating heart failure and kidney failure, because if the heart is too weak to pump the blood to and through the kidney, or let's say we have a good pumping heart and it pumps the blood to and through the kidney, but the kidney is sick, it cannot filter. Either way it goes, both condition will end up having the patient have a hypervolemia. You understand? And again, if you have hypovolemia, your heart rate goes up, immediately your cardiac output is compromised. Stop at this point, stop thinking, okay, PTT, that's heparin, then antidote is protamine sulfate, because this is the difference between standardized. It prevents instructors to conform the question based on the student's performance. When they give you the board exam, they don't have special group of questions for certain level of understanding. They expect you to understand everything the way everybody else understand it, because we're going to be taking care of patients. Okay? So you need to spend a lot of time studying. I want to advise you guys to make sure you create a schedule. Your schedule should include everything. Work schedule. By the way, I advise you, I highly recommend that if you are working and you're working a lot of hours and you had to repeat any class in the past, I wouldn't take a gamble on that towards this course, because this is when you still have ample time to catch up. If you find something that you were supposed to learn in introduction and intermediates, you still have ample time right now to understand it, because whatever it is, I guarantee you it will connect to what you're learning now in this course. So create a schedule, short increments of study time. Take a break. After you come back from your break, before you move on to the next topic, go ahead on and see if you can recall all the information you studied about this one topic before you go to the next one. Then take a break again. I always recommend an hour study, an hour break, an hour study, an hour break. But you cannot study 5 hours before the test and expect to do well in the proctored exam and the content mastery, especially not in the exit exam, because exit exam, they're going to mix everything that you have learned from beginning to the end. That means there's no certain announcement of what they were going to ask you or what subject is it from. Is it med-surg, OB, pediatrics, mental health? What is it? They're going to go ahead on and simulate the same thing they will do to you when you take the board exam. So I really recommend that you guys do not try that 5 hours, or I'm going to work and then when I get off 5 hours before the test, my test is until 12 noon. So I can just go ahead on and stay up until 2, 3 o'clock. Don't do it. Please don't do it. It never works. You might get a good score because you might get a little nudge, a little, help with your instructor, but I guarantee you it's not going to work. So please, please, please start going over your content mastery report from previous. Start with the fundamentals, the first one. Second one is, I think, mental health, right? Then pharmacology, and then there's OB, then pediatrics. Go over those topics. I guarantee you you'll be ready for the exit exam. That's what you want to do. And God, please, please, please believe me when I tell you, there's a high percentage of students who actually complete the VATI, who actually scored good in the board exam and passed it. People will say, okay, I'll do it on my own. I don't want any coach. I don't want nobody breathing on my neck. Yeah, some might work well with URoad, some might even work with what else is the other product there. But at the end of the day, not everybody actually succeed in using those products. Bati is free. It's part of the deal. They give you a certain amount of money when you complete the Bati. If you really want to use UWorld or Mark, it's Mark, right? And then what's the other one? What is the other product out there? If you really want to use that, why not use it with Bati? I'm just saying, if they're gonna
I have a
give you money,
question. When are we gonna get the access to use the baddie?
when
Nobody
you get
has
to
told me that.
493, when you get to 493,
Why that far?
because let me ask you this: do you have time for anything right now?
Well, I make time. If I have the resources, I absolutely make time to do stuff. I'm
Make
just
sure you understand everything that you have to understand in the advance first, because this is the last hoorah in the med search. If it doesn't make sense to
I
you, go
see.
back to
Thank
the
you.
intermediate. You go to your intermediate and the fundamentals. Med search is the foundation of any type of nursing, whether you go to OB, pediatrics, mental health. You know, med surg, you'll be able to survive any unit. You understand? You go to ICU, you go to recovery, you go to OB, you're gonna need med surg. That's why you notice those other courses is like, okay, one term, but in med surg, you had it in beginning, you had it in the middle, and you're also going to finish this end. So just make sure you guys don't do shortcuts. Go with the flow, trust the process, trust the system, trust us, because we're not going to lead you wrong. Okay? Any other question?
Can you explain acute respiratory failure? So, like the difference between that and ARDS.
Acute respiratory distress is something acute. I got shot, I got stabbed, that's distress. Acute respiratory distress, right? Respiratory failure is because it can be because of COPD, asthma, emphysema, something that's already cooking up for a while. So I always say chronic failure, right? Distress. I'm in distress. I'm so in distress. What do you mean, right? Right at this moment, I feel so stressed out. That's how you have to relate when you guys have certain things that you get confused, relate it to something that you might be familiar with. Does that make sense, Catherine?
Yeah. So ARDS usually happens when there's like trauma. And then acute respiratory failure is when um like the body is trying to compensate because of the lack of perfusion, but it leads to oxygenation failure.
It's because of a long-term thing.
Mhm. And
So think of distress, acute, failure, chronic.
okay,
Does that make sense?
yes.
So
And
I want you to remember that, so that no matter what condition they present to you, and they're saying, okay, what is this patient suffering with, right? If you see that they set it up and they're giving you something acute, that something just happened to the patient, then you know you're looking for acute respiratory distress syndrome.
Mhm.
See? If they're talking about, okay, patient with COPD, what's going on with the patient? Respiratory failure.
Right, because
See? Because it's COPD, it's a long term.
mhm, it's chronic.
Yeah,
Okay,
easy, right?
thank you.
You're welcome. Anything else?
I do have one question. I haven't looked into it myself, so I'm sorry I'm kind of throwing it at you. But with the ABGs uncompensated and compensated, I had a problem where the pH was normal, but both the bicarb and the PaCO2 were abnormal. And that's where I got stuck.
Okay, so when the pH is normal, that's a full compensation. So when we're not looking at full compensation, it's easy to determine which one is acidotic or which one is alkalotic, because if it's lower than 7.35, we know it's acidic, right? If it's above 7.45, then we know it's alkalotic. Now, If there's a full compensation, your pH is going to be normal. But how do we know if it's acidotic or alkalotic? Exactly what it says here. You see this? Can you see
Yes.
it? Okay.
Yes.
So this is what you have to remember. Anything between 7.35 to 7.40, you're going to call that as acidotic. 7.41 to 7.5, you're going to call that alkalotic. We have to have either acidic or alkalotic pH because that's how we tell if it's metabolic. If our pH goes the same direction as the HCO3, we know we're looking for metabolic. If the pH and the PaCO2 goes the opposite direction, we know we're looking at respiratory, right? That's why it's important for you to remember this. Because by looking at the pH, it's normal. Good, full compensation. Partial is all of the three components that you see there are all abnormal. But remember, I always said if they throw numbers at you, you want to always check. You're going to focus on PaO2 because that's oxygen, arterial oxygen. That
Yeah,
is
that was
that
helpful.
beats that beats all of this. If this is 60, 40, 30, patient is not able to hell with the rest of these other stuff, okay? We need to worry about the oxygen because that means your patient is suffering from hypoxemia.
Thank you.
You're welcome. Destiny, I remember your name. I've met with you before, right?
Yes.
Yeah, I remember that name.
In person, I'm a FYS student.
Oh, that's right. Okay. Well, guys, since you guys don't turn on your camera, when you see me in the hallway, just if you're there's always I used to say when I used to teach either I always tell my students be careful how you run to me because I don't know if you're gonna stab me or hug me because I used to challenge them very badly. But yeah, if you see me, guys, since you know what I look like, just introduce yourself, and then so at least I can be familiar with your faces. Okay? Anything else? Cindy, have I met with you also? I remember that name. Cindy
Yes,
Martinez?
yes, you have. You know me very well.
Oh, okay. See? See? I remember some names. Catherine, I've met with you too, right?
Yes, you have.
Yeah, I remember that name too. Yeah, I remember names and I'm really bad with names, guys. Trust me. So for me to remember your name, you have reached out to me more than once. So, and I appreciate you guys. Keeps me busy. So don't let the first quiz scare you. But when you take your first quiz, use that to make changes, right? If you got an 82, aim for 88. If you got an 88, aim for 96. Because the better you perform, that means you know this stuff and it will be easier for you. And let me just share this with you. I will announce the ATR Proctored Prep Workshop, but most of the topics are actually from your weekly learning objectives. Stroke isn't going to be there, right? DKA, HHS, that's very common in the content mastery. I get list of topics, but I just don't know how they're going to ask you. But I get the list of topics, and most of them, if you learn your weekly learning objectives, there's no reason why you will do poorly in your proctored exam. So just aim to learn the weekly learning objectives week by week, then you'll be fine. Anything else?
Yes, is pre-oxygenate and hyperoxygenate the same thing? I noticed that they use both of those terms in the questions on the test today.
Which one? The
Um,
hyperoxygenate and oxygenate?
some questions said should you pre-oxygenate the patient? Other questions said hyperoxygenate the
Yeah.
patient. So I was just wondering if they're the same thing.
Yeah, they use it interchangeably at times. So what it is there's a oxygen button in the mechanical ventilator and it says 100%. That's your oxygenated, your pre-oxygenation button.
Thank you.
You're welcome. Anything else? It's kind of cool once you see it. It's you can't miss it. It's commonly like in a very green. It's like 100%. It's like hello right there in front of you. So it will show you. I can't find a picture. I can't find a picture. Okay. But remember, every time you have a mechanical ventilator patient, you want to elevate the head of the bed, right? Semi-fowlers, because what does elevation of the head does to the lungs?
Doesn't it help it to expand?
Very good. Ah, I remember you too, Alexis. It promotes lung expansion. That's why you want to go ahead on and elevate the head of the bed. All right. Any other question? Phil, yeah, I remember you too. It takes a minute. You know, your grandma needs a little while for me to recognize names, but you'll get there.
Hi.
Hi. Any other question? Sylvia, I remember you too. Paula, I remember that name too. Any other question, guys? No?
Thank you,
All right.
Professor.
Thank you. Did everybody check in?
Thank
Anybody
you.
needs? You're
Thank you.
welcome. Thank you for
Thank you
coming,
so much.
guys. You're welcome. Thank you so much for coming.